Thank you, Shripriya, for that very elaborate introduction. Thank you so much. And I'm really happy, as always, to participate in such sessions organized by Pallium India. I hope I will be able to share a little bit of my experience with everyone. At the same time, I would like to tell everyone that I'm actually traveling. So I would like to switch off my video so that the net connection is on till the time we talk, we interact. And okay, so not going into much more talks, I would like to share my screen. First, just switching off my video. So is this, everyone can see my screen?
Yes, ma'am. Even though not in presentation mode, it is visible.
Yes. Okay, so I'll make it on a presentation mode.
Yes, ma'am. Good to go.
Right? Okay. So we're talking about ethics in palliative care today. It's a very important topic, and we generally face with certain situations day in and day out when we are dealing with our patients, not only in palliative care but practicing medicine as a whole. So it's important that it's very easy to remember the ethical principles or the ethics that guide us for our day-to-day practice, but it's also important that we weigh the pros and cons of applying such principles in our practice so that we can save ourselves, and at the same time we can do justice to our patient and justice to what we decide for our patients, right? So so we'll go through the presentation in these three topics: definition, the four cardinal principles of ethics, and then euthanasia. Euthanasia is one topic that we all must know. What is the importance? Whether there is any kind of term called euthanasia or not. So all these things we'll come to know after we discuss. So by definition, ethics are a moral code of behavior, and the principles are, those which should function as an analytical framework that expresses the general values underlying the common morality. So basically, we are talking about moral values that we apply for practicing medicine, and how we connect our morality, our common sense or common morality with such principles. So in palliative care, the ethics are exactly those of general medicine. And we have to understand that we as doctors have dual responsibility. Number one, we have to preserve life. And number two, we must relieve suffering. So these are the two moral responsibilities of a doctor, of a practicing palliative care physician. And having said this, at the end of life, the relief of suffering becomes more important as preserving life becomes increasingly impossible for us, because we are not gods. We need to understand that fact. Unless and until we ourselves consider as human beings, prone to error, we will not be able to make others understand this fact. We will always be kept on a higher platform that we are gods. People will keep on expecting so many things from all of us. And when we are not able to fulfill those expectations, it will hurt them and it will bring a lot of dissatisfaction to us. So there are, four cardinal principles as applied to palliative care practice, and these are patient autonomy, beneficence, non-maleficence, and justice. I'm sure you all know about this, but autonomy means what the patient wants, and here in palliative care, we have to understand what the patient's family understands about the patient's preferences. So, it is important that we understand the difference between taking care of the patient's understanding about the disease, and at the same time, what does the family also understand the perspective of the patient or not? That is also important. The family may have their own preferences about the patient's disease, but the family must understand what the patient is wanting, or what the patient understands about the disease. So there is a gap here which we generally see, because we do see that patients are being told or protected by the family in certain situations, asking the doctor not to say give him the diagnosis, and so many other things. Beneficence, of course, will it benefit the patient? Will our actions, taking, prescribing a certain medication or intervention, is it going to benefit the patient? Non-maleficence, for that reason, will it harm the patient? Is it going to harm our actions? Are it going to harm the patient? And justice, allocation of resources, fair utilization and allocation of resources is justice. So, what are we actually, why are we talking about ethical principles? I mean, we know that, we have to do beneficence, we have to give autonomy to the patient, not do maleficence, we have to fairly allocate. So why do we generally, where do we see ourselves here? So the problem in following ethics is that we are always in a dilemma, because there are certain situations where we feel that one of our actions are going to benefit the patient, but then sometime the patient doesn't want it to happen. He refuses or something, and we go on banging on the wall that no, you'll have to do this, otherwise you're not going to get better. You try to kind of hammer things on the patient and the family that no, you have to take it, this is important for you, and so many other cascade of things actually go on happening. So these things, these situations actually lead us to something called the ethical dilemma, and it is a conflict of moral principles. That is, you can actually read this slide. So it occurs when a person faces certain situations where adhering to one particular principle might result in the violation of the other. Now, we have to see whether, violating the other principle does good or does bad, and how is it justified for us to violate one of the principles and then go on following the other one. So what do we generally do in ethical dilemmas? How do we manage ethical dilemmas is the question. So I'm going to give you examples, and I would like to take your responses too. I know there'll be questions, and I'm really ready for it. It's I know that you'll have a lot of conflicts or dilemmas right now going through this particular thing. So you can actually see this is a patient with a jaw tumor with an orocutaneous fistula. He's an elderly patient in pain. The disease per se is localized, but we know that the patient should have an NG tube insertion, but he's refusing. Now, I would like your response on what is going to be our stand in this. Can I have some responses? You can actually give your responses in the text box, and maybe we can just, after that, we can talk about it. Yeah, any responses? Anything in the chat box?
Nothing in chat box till now. Yes, Dr. Sara says parenteral feeling.
Parental feeding, okay. Okay, and anything else?
Dr. Vandana says counseling.
Counseling, okay. Anything else? We can explain the patient regarding the importance of nutrition, all right. We can explain the need of the NG tube, right? So that's what, counsel the patient, try to convince if it is really needed, and do with controlling pain, okay. Ask them why they're refusing. Ask him about patient's apprehensions about NGT, okay. Explore why he refuses. Counseling other options. Okay, so I've got a very good response. Okay, see, somebody's saying patch for relief, counseling the patient in need of tubing. Sorry, explain other options and approach. All right. So we do have a good number of responses. So now, so this is a dilemma, because we want to benefit the patient. We want to do good to the patient by inserting an NG tube. And, the patient choice is also there. It matters. He's actually refusing for an NG tube. Now, what is our stand? So let us first see what is patient autonomy. Why do we want to do a benefit to the patient by giving him a Riles tube or an NG tube. Now, why are we having this conflict between the autonomy of the patient? We have to find out what is it. So the patient has to be involved in decision making. That is the point of prudence out here. So the right to have the dignity, privacy, and confidentiality, the right to have information, the right to make decisions, and last but not the least, treatment decision has to come as an informed choice of the patient, right? So these are the four pillars, or the four contents, most important contents that patient autonomy holds. And that is why the patient, when in a conscious state, have to be involved in decision making. After all, this is my body. I am responsible for any action that I take for my body, whether it is detrimental, whether it is beneficial for myself. I will take the decision. So we have to respect this particular thing, right? This particular. So for this patient, what we need to see, why the patient is refusing. Everybody, most of you have actually, given out this particular thing, that we have to explore the reasons why the patient is, actually refusing it. Need to understand whether the patient has understood the importance of giving this Riles tube, and then counsel the patient why he is apprehensive, if at all he is apprehensive. He may not be apprehensive, but then still he is refusing. So the point here is, support the patient even if you do not agree with the decision, right? You are not agreeing that the patient will not take a Riles tube or the NG tube, but the patient choice is number one. You have come to a decision that the patient has understood the pros and cons of taking the NG tube. You have also explored the reasons that, the patient, why he is not taking this NG tube. You have tried to counsel him, not hammering. There there's a difference between the thin line between counseling and hammering your decisions. So you need to, counsel him by giving him all the, laying out everything on the plate, right? Across the table. You have to give him the benefits. You have to show him the problems also of taking the Riles tube. So you've counseled the patient, you've given him the choices. Now still the patient does not agree to it, and you too are not happy about this decision. Even when you're not happy with the decision, you have to support the patient. Be by the side of the patient, even if you do not agree with this. And this whole thing that we have done is called taking an informed refusal from the patient. Take it in writing, right? It's not like that, नहीं नहीं आप हमको लिख के दे दीजिए, आप नहीं ले रहे हैं, बाद में कुछ प्रॉब्लम होगी. It's not like that. You have to make him understand. You have to empathize with the patient. You have to make him feel that it's okay. Even if you don't take, I am with you. I do not agree with your decision, but still then I support you in your decision. And, in my experience of these few years of palliative care, I have actually come across patients who have refused an NG tube where, the doctor, the team have actually found out that feels that NG tube is going to help this patient. The patient, after, maybe a week or so, has come back to us and said that, doctor, you were right. I need to take this NG tube. You have to give the time to this particular patient. Even if he refuses the NG tube for the first time, you need to give the time to recuperate, to understand, to absorb all the information that you've given. So give the time to the patient. Coming to another case. So this is a 20-year-old boy with osteosarcoma of the lower end of the femur. He now has a large tumor, multiple lung metastasis, and severe anemia. Now he wants an amputation right now, but the procedure is too risky considering his general condition. So you explain the risk to him, but he wants to continue with the amputation. Okay. So now what to do next? Can I have some responses? Any responses? Okay, so this is a dilemma. Yes. Okay, so I have something to chat. It's a reason for surgery. Even if he wants, if it is going to harm, check if informed decision, okay, we should not go for it. Amputation is anyway not the treatment for this stage, okay. Take second opinion, explain the consequences if willing to do with high risk consent. All right, so yes, we have some. So this is a dilemma between doing good and avoiding harm. So we want to avoid harm and do good to the patient, right? Yet the patient wants it. So, you actually have to look at, what are the chances of cure in this particular patient, right? The patient wants an amputation because he feels, or he has read somewhere, or he has come to know, or he has been told by somebody that amputation, isko काट के फेंक दो तो ठीक हो जाएगा. Understood? So his understanding is that this is my cancer. This is where I have got the whole lot of pain, and I need to cut it out of my system. And then only I'm going to get well. Why are the doctors not doing it? He's angry at us. So we have to make him understand what are his chances of cure after doing an amputation. Number one. Number two, the most important question, is he really going to survive after the operation? Right? Do you really think that, if we cut out this whole big tumor on your thigh, is it not going to bleed a lot? Is it not going to carry away all the nutrients that is present in your body? Are you really going to survive after this big, huge operation, which might also, take your life? So this is an important question. Will the amputation improve his condition? So this particular question, these questions, these are the things that you will need perhaps to tell him that these are the situation. This is the situation where you are in right now. You have a lot of metastasis in your lungs, which are perhaps not going to let you breathe in the required amount of air or oxygen, which might be important for you to live after the or during or after the surgery. And anyway, this treatment may not be as good as you think. It is actually detrimental for you. So these particular questions, you have to, talk it out with the patient. It's a young person who that has not accepted the terminality of his disease, and he wants to live. The thing that is hanging on in there is the hope of continuing to live after doing the surgery, after doing a lot of radiotherapy, also after doing perhaps chemotherapy. So his hopes will continue, and this is the thing which he's trying to cope up with the situation. And we will need to understand this particular situation of an ethical dilemma, where we don't want to do the surgery, right, and the patient wants the surgery. Okay, so another dilemma, another thing: a 20-year-old boy with advanced cancer is under your care. Relatives have insisted that issues of diagnosis and prognosis should not be discussed with him. So when you go to see him one day, he's all alone sitting on his bed, and he asks you what is wrong with him. So what will you tell him? Let us know from somewhere. What will you tell him? Yeah, any responses? Should we tell him that what his cancer is advanced?
We have responses coming in, ma'am. Let Dr. Kanmani, please ask him what he knows about his illness, what has been told to him by the other team members. Ask him why he wants to know.
Okay, yes. Assess his mental status and inform him. All right. Asking what are his questions regarding disease. Ask for the patient if he wants to hear everything about his illness. If he wants, we should tell the truth. At the same time, we explained his relatives about the importance of the truth telling. Okay, we should talk with relatives that he is major, and we have to inform him about his condition. Okay, seek to understand what he knows already, and he or has deduced himself. Ask him what he understands, and does he want to know? Yes, tell him and explain why their family were against telling him. Okay, he has a right to know what he is suffering from, but should be told in an empathetic way. Very good. Patient has a right to know. Doctor has the obligation to tell the patient, and the patient has the right to know. Right. So everyone has actually agreed that we should tell the patient. Okay. So even if the patient is a 12-year-old boy, 6-year-old boy, they have the right to information. If you remember the first slide, which talked about patient autonomy, the important thing that we had out of the four things were, the right to information. Every patient has the right to information. It is on our, onus, or, our responsibility, how we give that information to the patient. Number one, are we going to lie to the patient? No. Number two, are we going to bang on the patient that, oh my God, you have advanced cancer, you're going to die within 2 or 3 days or weeks? Are we going to do that? No. So what comes in here is our communication skills, breaking bad news or communicating bad news. Here you are going to communicate bad news to the patient, despite the relatives, asking you not to do that. Now, we may have to explore why the relatives want to do that. See, for parents, a 20-year-old or a 30-year-old even would be a child to their parents, right? For me, I have an 18-year-old son, and for me, he's still 8 years old, still 8 months old. Okay. So I will be definitely protective about my son, and I will never let him get hurt by a slightest of mistake of anybody else, not even mine. Okay. So here also it's the same situation. This boy is a 20-year-old boy. The parents or the relatives had, they are insisting because they're protective about him. They will understand. How will they tell you actually? No, sir, please don't tell him. He'll get hurt. He will have a heart attack. What are they actually trying to express? They are trying to express that they are protective about, their son. They are trying to protect him from getting hurt, from getting depressed after seeing this. Now, what we need to make these people understand is that the patient is an intelligent person. Whether the patient is a child or the patient is an old, aged, elderly person, whether the patient is a young, professional, whoever, every patient for us is an intelligent person. The body of, my body, I understand my body better than anybody else. Even if the doctor claims that he knows my body, I will not take that for granted. It is my body, I understand. I am not feeling well, I have a headache today, I have a, I feel nauseated today. This is my understanding. It is subjective. So we have to make that these people, these relatives understand that, this patient of theirs is an intelligent person. He knows what the body is going through. He has the right to understand what is the diagnosis and how far it is going to take him, And once you make them understand these things, you may have to, sit with them for 2 or 3 sessions altogether. At one point of time, you might also face some kind of anger from them, but it is on your communication skills, your patience, because you want to do good to this patient and of course to the relatives also, making them not lose their hope of, getting the best treatment from you, because nobody else is going to do that at this point of time. Okay. So, you are right when you say that you will give the diagnosis, you will tell the diagnosis to this boy, but then you'll also have to take care of the fact that the relatives have insisted you not to say this, and you may have to sit with the relatives, maybe at one point of time, ask them, everybody, all of them, to sit together with with their son, and then do a discussion on what is going on and how to, uh, take this next step forward. So that is how we are going to manage this particular dilemma. So yes, it does actually talk about, deliberately misleading a person or to withhold information that the person is asking for at the insistence of the patient's relatives. It is, if we are not going to do that, if we say that, nahi, nahi, beta, aapko kuch nahi hua hai, you are perfectly fine, we are actually continuing with the treatment is taking some time, but you must have hope, you're going to get better, you're going to go out of this hospital, go to your school or your college. That is actually kind of misleading. Even if we try not to say that, one after the other, when we start talking about giving a kind of a false hope to the person, ki nahi, theek ho jayega, the sequence of communication that happens is naturally will prompt you to give some kind of false hope to this patient. So that is why you must not actually withhold any kind of information from this patient. So another case, it's a 50-year-old lady with carcinoma of the stomach. She has come to the hospital in a terminal state. Now, this, state may be due to an internal bleeding, and her systolic BP has hence come down to 50. See, she's extremely restless. Now, the question is, will you give her parenteral midazolam, which may hasten death? Now, I want to take some responses. Any responses on this particular case?
Dr. Vandana says we may, as it will decrease her suffering.
Okay.
Dr. Jaya is also of the same opinion.
Yes,
Dr. Sarah says inform and take consent.
Okay. Okay.
Dr. Vandana again says anyway we can't save her. Jaya says it will decrease the anxiety. Most of the opinions are like we should take consent.
We should, if there is no curative treatment available and reduce the suffering, in relief is a priority. Okay, so I go with everybody. Will this be ethical? That's what the question is. So I don't know who is, okay, Kanika, Dr. Kanika, I think. First, we should try other drugs which will not decrease BP, but if it is needed, we should give, okay, as it is in end of life. Okay, to control resistance, important life, so midazolam should be given. Okay, yes, after informed consent. Okay, so is it right to give some medication to a terminally ill person which may inadvertently hasten the person's death? Will it be right to do that? Midazolam in this particular patient may inadvertently hasten death. So will it, we know it, midazolam might hasten death. So will it be right to do that? Oxygen, blood, go for midazolam. Okay. Can anyone give me this answer? So the point here is, okay, we have something in the chat, is it?
Yes, so, yes, but all the family and patient should be aware and in agreement. Okay. Dr. Sarah says sanctity of life should be kept in mind. Dr. Ashwini is of the opinion that you to discuss with the family and patient. Dr. Revati had hinted about advanced directive. They have any advanced directive?
Okay. Okay. So the question was, the patient is extremely restless. Okay. Now, we know that terminal restlessness or terminal, agitation, the gold standard is midazolam, IV midazolam. Okay. And by giving IV midazolam, you are actually giving relief to this patient. As there were other, in the chat box, we had this particular answer to the question. We are relieving the suffering of this terminally ill patient. I think, the question was that the patient perhaps has an internal bleeding, okay, but at the same time, the patient's BP has fallen to around 50, and the patient is extremely restless. And restlessness is suffering for a terminally ill patient. What do we do in the ICU when the patient is suffering in restlessness? We just tie their hands and feet, don't we? And that is the most, notorious thing to do. That is the most, it amounts to some kind of crime. I really feel like that. Instead, we should try out midazolam to actually relieve the patient's suffering. Okay. Excuse me. But at the same time, we also know that midazolam is inadvertently going to perhaps hasten the death of the person. So how do we manage it? As many of you have rightly pointed out, we need to talk to the relatives. Okay. Paperwork, documentation, resuscitation, everything will go parallelly to whatever our decision is. But then the main thing that we are going to do is relieve the patient of the suffering, which is restlessness. And having said this, we must also take the relatives into our confidence that we are going to relieve the patient of this suffering by using this particular medication. But, the side effect or the other effect of this medication is that it might, during the sedation, it might so happen that a patient leaves all of us. So we have to prepare these people beforehand. We are going to face a lot of challenges at this point of time. But having said this, again, I reiterate that you must use your communication skills. You have to take quick decisions, and you have to sit with the patient's relatives, give them the information that is required, show them that empathy which is required at that point of time. And nobody else can do it except you and your team. Right? So have confidence in yourself. You're going to face these kind of things when you're working in a, setup where you get terminally patients, and, people end up in a lot of conflicts because of such ethical dilemmas. The very, your own fraternity, your doctor colleagues will actually point a finger at you when you try to take decisions in this manner. But, having said this, dilemmas can be averted, can be, solved, can be managed by usage of a strong academic base, because you're not doing it out of your own mind because somebody has told you about it, but you've read about it, it is a research, scientific basis of taking care of restlessness in terminally ill patients. And always remember the principle of double effect, which I'm sure you must have learned by this time in other classes. And this definitely does mention about, the usage of any drug or an action, a medical action, which might prove good for a patient, and at the same time has an undesirable effect, which might cause an undesirable side effect for the patient. And here, usage of midazolam for terminally ill patient in restlessness is the gold standard, and the other effect being inadvertent hastening of the person's death. So yes, this is the principle of double effect that I was talking about. So this is another ethical dilemma. This is a 74-year-old gentleman with advanced carcinoma of the lung who had completed a course of radiotherapy and 2 courses of chemotherapy, is brought to the casualty. He's drowsy, his pulse is feeble, he has a systolic BP of 60, and the breathing pattern is altered. The family wanted everything possible done for him. So what do we do in such a situation? Do we resuscitate and shift him to the ICU? Do we do n number of investigations, CT scan, PET scan, or whatever, and then perhaps do a hemodynamic and ventilatory support also? What about hydration and nutrition? Can anybody give me some responses to these questions? So in this case, we need to see something which is called an appropriate treatment. And it is that treatment that does not provide net benefit to the patient, may ethically and legally be withdrawn. And the goal of medicine should shift to palliation of symptoms. Okay, this is a 74-year-old patient with an advanced CA of the lung, perhaps maybe living for another 5 to 6 hours or 24 hours at the max. And, the family is an affluent family, has a lot of political connections. Right at the time of landing in the hospital, they had numerous phone calls going on from one person to the other. Somebody calling up the medical superintendent, somebody calling up somebody else in that particular situation, and they are trying to do something to help this patient live for another few months or whatever. They want to put him in the ventilator. They want to actually stamp that, yes, I have done everything for my father. So now we need to understand the appropriate treatment options for this particular patient. Yes, if the patient is restless, we need to palliate that patient with midazolam. If the patient is hemodynamically unstable, we might as well consider usage of a subcutaneous infusion line of maybe a normal saline or a ringal lactate. If the patient is having a lot of secretions, those might be troubling that patient for in the breathing pattern. We might as well consider a little bit of buscopan to clear out that secretion. Okay, so these are the palliation of symptoms. This particular goal is palliation of symptoms and not exactly doing something to save this patient. So we have to understand withdrawing a patient from the ventilator, from the curative point of option to palliation of symptoms. So the appropriate treatment key points would be to see the biological prospects of this patient, the therapeutic aim and benefits of each treatment that was given earlier and now planned, okay, and the adverse effects of each of these treatments. And these need not to prescribe a lingering death, okay. So we have to look at these 4 important key points when we talk about appropriate treatment for a patient of such a terminal illness. So this brings us to balancing the needs of the individual with that of the society, which is the principle of justice. So what do we have here? We have another patient who's a 86-year-old journalist. He was a war correspondent. He has number of things to for his virtue, like he was a thinker, he's a writer. But then he landed up with CL lung, spine, rib, and the sacrum, all metastatic. And unfortunately, he has one son who has a psychiatric disorder, 6 grandchildren to look after. Now, the goals of care that would actually surround this particular 86-year-old person is taking care of the pain, perhaps, looking at the family finances, because already the son perhaps is not working anymore, has a psychiatric disorder. He has already 6 grandchildren who needs to be, educated and settled. And then, some kind of Janevu sanskar that the 3 grandsons might be wanting to do, right? And at the end, when the breathlessness increases, what would be our goal of action? Should we consider an ICU admission for this patient? What about, there is just one ICU bed for this, for such a patient, and, we've already weighed out his chances of survival and other things to be looked after. But at the same time, there is a 20-year-old motorbike accident person who lands up in the hospital and needs ICU care at that point of time. So this brings us to the principle of justice, where we need to do a fair allocation or fair utilization of the resources that we have, the family's resources, because the family is already, perhaps overburdened with no income and, very less resources to look after this 86-year-old gentleman. What about the, resources of the hospital, right? We have just 10 beds in the ICU, 9 have been filled up, only 1 is left. And at the same time, we have 1 patient who needs ICU admission, a 20-year-old motorbike accident person, So of the societies and the nation's resources, where we have so many people, living under the poverty line, the healthcare resources are not reaching our poor people on time. So these things generally come into the principle of justice. So this brings us to, something called euthanasia, where people unable to, see the sufferings of these people, their own loved ones, would actually want them to go away, right? So it's an act or procedure in which someone takes active means, such as a lethal injection, to bring about someone's death, okay? So you have to understand that allowing natural deaths, okay, which includes withholding or withdrawing a futile treatment, is not euthanasia, right? So there'll be cases when you learn about the end of life care in your subsequent classes. I'm sure somebody is definitely going to talk more about withholding and withdrawing futile treatment at the end of life, especially for terminally ill people. Okay, at that point of time, you will need to understand the fact that when we allow natural death to take place, we are not actually doing euthanasia. Okay, so uh, it it is legal in Netherlands, Belgium, and Luxembourg, but it is not as equal to allowing natural death. Okay, so there is a legal provision in IPC section 88, which says that just a minute. Can I take this call, Sri Priya, just for 1 minute?
No worries, ma'am, please.
So we were talking about the legal provision, which is the IPC section 88. So you see this provision, it justifying acts not intended to cause death, done by consent in good faith for personal benefit. Okay. Unfortunately, we do not have much experience of translating this particular legal provision into clinical practice. Okay, so what is the crux of the whole thing is that we do things in good faith by taking a consent. Okay, but we seldom do it, we don't have much experience of doing it in a legal process. Okay, there is no legal provision of doing this in a clinical scenario. So that is the main problem with this particular act. And then when we talk about futile care, physicians are not ethically obligated to deliver the care in that their best professional judgment will not have a reasonable chance of benefiting their patients. This is the AMA code of medical ethics. If you go through that, you'll actually find it in that that physicians, while giving a futile care, they are not ethically obligated to deliver care in their best professional judgment, and they will not have a reasonable chance of benefiting their patients. So as physicians, if we are asked to give some kind of futile care, we can actually quote this particular code, where we can say that we are not obliged to do any care which will not benefit my patient, right? So why do doctors go for futile treatment at all? What is the problem with our doctors? They are oriented to curative treatment, number one. There is no training in palliative care because most of the time ethics, withdrawal of treatment, euthanasia, everything are taught in palliative care only. That is what we see. There's always a fear of being blamed for suboptimal treatment all the time. The ignorance about the guidelines for end of life care, okay, and the question of euthanasia. There is actually no such term as active or passive euthanasia. Euthanasia is always active. It cannot be passive at all. Okay, because when you are performing something to, kill the patient, actually you are performing euthanasia, right? But if you are allowing natural death to happen, okay, we're not doing anything to perhaps we are allowing the patient to progress or proceed on the natural lines of deaths. We are not at all performing euthanasia. If you're interested, please go through these particular guidelines. It is available in Indian Journal of Palliative Care, also in the Journal of Critical Care Medicine. You'll see that there's a end of life care policy, and they have, properly lined out a 12-step guideline for end of life care, where withdrawing, withholding treatment, how to approach a patient, how to approach the family, what happens after the patient lands up in the ICU, how do we withdraw ventilation, how do we withhold ventilation. Everything has been lined out, and I sincerely request all of you to please go through this particular paper. So you see, there is a kind of a difference between killing and letting die. Okay, what happens is that the distinctions between killing and letting die, it becomes a little problematic. So there is a moral prohibition for killing. I hope you all agree to that. A moral prohibition for killing, but people invariably will die at some point of time. Okay, so it is a fact that sometimes the dying patients are given futile treatment, which will compound their suffering. And so there is a need for letting the patient die. Okay, so this will necessitate the withdrawing or withholding the treatment. And with the advent of modern technology, the distinction between killing and letting die might appear a little blurred, okay, in some situation. Okay, you will feel that you are actually letting the patient die, but at the same time your ethical dilemma will prompt you to think that you are actually killing the person. Okay, now the point here is that prolonging life is good, extremely good, but prolonging the dying process cannot be considered good. Okay, so we have to make a decision between killing and letting die. So you have to understand the difference between these two important terms. So, as such, euthanasia is a deliberate intervention undertaken with the expressed intention of ending life to relieve intractable suffering. Okay, it's a deliberate action. So when it is a deliberate intervention, it cannot be passive, it has to be active. So there is no term called passive euthanasia. Today's take-home message for all of you is that there is no term called passive euthanasia. Euthanasia is always active, and hence we do not support euthanasia because we don't want to kill our patients. Okay, we want natural deaths to happen to all our patients. We do not want euthanasia to take a active term. So bringing us to something called do not resuscitate. Okay, so India has come to a point of healthcare where we have advanced directives, um, and we generally have people writing their advanced directives in big corporate hospitals, and slowly it's also trickling down to smaller hospitals also. Hopefully at one point of time, we'll have our government hospitals also writing down advanced directive protocols for our patients. So just asking people out here, uh, is using morphine and other drugs to relieve pain called euthanasia? Stopping treatment when the burden outweighs the benefits, is this euthanasia? And allowing nature to take its course, will it be euthanasia? So I hope till now you have understood, what amounts to euthanasia and what does not. So palliative care uses all these three statements. We use morphine and other drugs to relieve pain. We might use midazolam to relieve restlessness. And at the same time, these drugs might cause inadvertent side effects, which might sometime also hasten deaths of the patient. But we are not actually doing any kind of euthanasia here. Okay. We stop treatment where the disease burden outweighs the benefits. For example, we do not put the patient on ventilation when it is not needed, and henceforth we are stopping treatment. And that does not amount to euthanasia. And of course, as I have been telling you since some time now, that we need to allow nature to take its course, and that does not amount to euthanasia. I hope you all have read this beautiful book by Atul Gawande. He has beautifully described about the terminal nature of disease and how our medical system, is excellent and trying to starve out deaths with chemo, intensive care, surgery. But we are not able to actually take death when it comes to us, right? So we sincerely cannot afford to die in the ICU, and these are the evidence that actually gives us why we cannot afford to die in the ICU. You can go through it later on if you want. So this is our take-home message for today. We need to apply ethical principles against a background of respect for life and acceptance of the ultimate inevitability of death. Okay. So we want to spend our last days. I would want to spend my last days as this woman has, with her family surrounding, and not inside the ICU. So that brings to the end of my session. Thank you so much for a patient hearing, and ready to take on all your questions, if any. And I'm really sorry for this bad cough that I'm having. Because yes, thank you so much. Thanks.
Thank you, Dr. Sanghamitra, and please do take good care of your health because anyways, your cough is not bothering us, but please do take care of your health. So the forum is open now for questions, if any. Yes, we have one question from Dr. Rishikesh. How commonly do patients outsource autonomy to relatives, even after proper counseling? And how do you confirm this on subsequent visits, especially if they are proxy visits?
Okay, it's a very interesting question, actually. See, as a in our Indian society, I am talking about our Indian society, I do not really see patients outsourcing their autonomy to relatives. Okay, because we are, when we see relatives point of view, they are trying to protect the patient from getting hurt, right? At the same time, the patient is also trying to protect his own family members from getting hurt, right? So this is where everything, the dynamics comes on. I don't want to hurt my parents at this particular age by giving them a weak front that I'm suffering from this. And I always want to tell my parents that no, ma, I'm absolutely fine, nothing is going to happen, don't worry. Okay, but the truth is something different. So very interestingly, Dr. Rishikesh, thank you so much for bringing this up, because I think we as doctors in this particular uh, format or this particular setup will need to be the mediators, to bring both of these parties, the patient and their relatives, to one common platform, so that they share their own sadness or their own feelings with one another, and that will actually strengthen and their bonding. That will also give them a lot of strength to carry on with the struggle that they are in, right? And at the end, when the patient perhaps leaves us, that point of time, the relatives or the parents or the brothers and sisters will not have this uh, thing, this particular burden on their heart, that they couldn't talk at length to their brother or their sister, you know so this is what life is all about. We are trying to protect our children, we are trying to protect our parents. At the same time, somebody who's suffering from this disease, which is terminally ill, is also trying to protect us from. It is a two-way mechanism. Okay, so our moral responsibility is that we try to bridge this particular gap between the two. Okay, and the second part of the question is, how do you confirm this on subsequent visit, especially if they're proxy visits? Well, um, I we do have proxy visits, that's true, but then I would not depend on the proxy visits at all. uh, so to say that I do not disrespect the other person's views, but I want to start it from the whole thing again and again. Try to revisit the whole process, try to revisit the story overall once again, so that the patient and the family member do feel that I'm totally involved, I'm a part of their story. Okay, I'm not an outsider who's actually coming in, giving a visit and going back. It shouldn't be like that. Is my personal take. Everybody has their own mechanism to do it, but then I do it in that way. You'll find your own ways while you do it, because your timings would be different, your setups would be different. You'll have different situations, you'll have different family members, different patients, different people, different persons coming on all together. The dynamics would actually be different. But then for proxy visits, I would sincerely not try to rely on them. That's what. So I think another comment is, usually rival relatives overstep. I think this might improve with increasing awareness. Absolutely, yes, I completely agree. And overstepping is also a kind of a protective mechanism. But sometimes what happens that there's somebody from the US, one uncle who knows a big doctor in the US, comes and then tells you that, in the US, this doesn't happen like this. And why are you doing this? So they try to give you some kind of gyan and things like that. But you've got to handle them also. At one part of their heart, they're also sad at whatever is happening. So your compassion and your, attitude will, bring them down to the level that you want them to be. Okay. So altogether, it's again your communication skills that will be tested all the time, all throughout. Your clinical skills will excel only if you have very good communication skills. Yeah. Okay, so Shri Priya, I'm really sorry, I need to go. I have a very important meeting coming up. I hope I'm able to make you all understand little bit about ethics and whatever is needed. My number, you can share my number if anybody wants to contact me. I'm really, really open to any kind of discussion. Yeah.
Thank you so much, Dr. Sanghamitra. Very insightful presentation. I think everyone would agree to that. And of course, as you told, since you have to go for an important meeting. Thank you so much for joining us. See you in any other coming sessions as well. And we do have a case presentation, and we have Dr. Sunil Kumar joining us to facilitate the same.
Okay, thank you. Dr. Sunil, thank you, sir. You saved me. Okay. Thank you so much, Sri Priya, and thank you everybody for this very interesting hearing and so much lovely comments. Thank you. Bye.
Thank you, ma'am.
Thank you.
So, continuing with our session, right now we'll be moving on to the case presentation by Dr. Vandana. Ma'am?
Yes, ma'am. Good afternoon, ma'am.
Yes.
Ma'am, I don't have the slides. I think you'll be sharing it.
Yes, I am
That should
sharing.
not be.
You can just
Yes.
read.
Yes, ma'am. Thank you, ma'am. Good afternoon, everyone. And I'm Dr. Vandana Kulkarni, professor in the Department of Anesthesiology, East Point Medical College and Research Center in Bangalore. Today, I will be presenting a case regarding medical ethics. So we had this patient, a 67 years old female patient, who was diagnosed to have intracranial bleed in the right side of thalamus with midline shift in a comatose state. This patient actually presented to our hospital in an unconscious state with a Glasgow Coma scale of 3/15. She was brought to the hospital by some local people, not by her relatives, in an unconscious state. So the history of illness was like all that was the people who brought her knew was she was a person who was selling flowers in the market when she suddenly collapsed. And then they witnessed it and brought her to the hospital. Because of this, there was a history of comorbidities could not be obtained. And then after emergency care, she was shifted to the ICU. So after a period of 2 days, the Glasgow Coma scale improved to 4/15, but it remained the same for the next course of 15 days. Coming to the examination, this was a 67 years old female patient not responding to commands and stimuli. She was moderately built and nourished. Her vitals were within the normal range. Her systemic examination, that is cardiovascular, respiratory, per abdomen, were unremarkable. But coming to the CNS, she was unconscious. And as I already said, on admission, it was GCS was 3/15, which slightly improved to 4/15, but remained the same later on. So treatment, now because when she arrived, there was no particular history available. On an emergency basis, she was intubated and put on ventilatory support because she was brought in an unconscious state and no history was available from the people who brought her. And she was started with injection mannitol 100 ml TID, injection levetiracetam, 1 gram loading dose followed by 500 grams TID. Of course, other supportive care was given. And then after that, when she was later sent for CT scan, it was found that she had a subarachnoid bleed in the right thalamus with a midline shift of more than 4 mm. Later on, over a period of 7 days, when she did not improve, the endotracheal tube was changed, and then the tube was sent for culture, which turned out to be positive for Klebsiella and E. coli, which was sensitive to meropenem and piperacillin. So coming to the psychosocial aspects in this case, patient being a flower seller mostly belongs to a lower economic income class. We actually did not know much about her family background because no attenders were present when she was brought. And currently the hospital is bearing all the cost of her treatment. Medications, she is currently being treated with injection mannitol, injection levetiracetam, and injection piperacillin. And the main concerns in this patient is that she is in the same state since last 15 days. There is no improvement in her condition. The hospital is bearing all the costs. There are no attenders who are available for giving any kind of consent, whether it is do not resuscitate or whether it is to consent for tracheostomy. The police were informed regarding this patient to find whether they can locate the attenders or relatives of the patient, but they were not able to do so. And they just asked us to continue treatment as long as possible. So to summarize, this is a 67 years old female patient belonging to lower economic strata brought to the hospital in an unconscious state by nearby people. She was diagnosed to have intracranial bleed in the right thalamic region. Her Glasgow coma scale was 3/15 on admission, but remained 4/15 since last 15 days. She was immediately intubated and put on ventilatory support and has been in the same without any improvement since 15 days. So the discussion points in this case would be, when there is no one to give consent, how should the patient be treated? In end of stage patients who are destitute, how long should the treatment be continued? Is it ethically correct to discontinue treatment in such patients? In case of attenders coming and questionings later on, how should that be handled?
Thank you, Dr.
Thank you very much.
So this is I think this issue might have faced by many of you, and I would like to hear from you how you have handled these situations in your hospital. Anybody has faced such a situation?
Sir, actually, can I continue, sir?
Yeah, let's hear from the participants if any of them have any comments. Anybody? No. Yeah, I can continue. Dr. Vandana.
Sir, actually in this case, and what we did in our hospital was we tried to cut down, the treatment was definitely not stopped, but then it was limited to what is required. The important point in this case is, sir, that there were no attenders, and what we were worried is in case they come and question us that if any kind of treatment is stopped, why did you stop, or these kind of questions might come up. So that was the worrying thing. So for that reason we had informed the police also. Now you can guide us, sir, better on what should be done in such cases.
Yeah. So as now participants are speaking, so when such a situation come, as per ethics, the patient is the supreme authority of what should be done to the patient. If the patient is not conscious and is unable to take treatment, the next option is the close relative. And If that's also not possible in this case, then the doctor should take the decision what to do. And if the doctor, one doctor is unable to take the decision, form a committee within the hospital. Uh, the committee should include, I think, at least 3 or 4 people, doctors from different departments. They should examine the patient, and uh, each of them should examine the patient separately, and all of them should sit together, and they should come out with a common decision about what should be done to the patient. So in the meantime, this should be informed to the police, which you have already done. And as per the committee which is instituted by the hospital, the patient need to undergo any treatment is needed, or if the present treatment is futile, then that need to be documented, and uh, and then if the treatment is futile, that treatment need to be discontinued. That's what can be done ethically. In the end stage of patients who are destitute, how long should the treatment be continued? Even in the end stage of the patient, if the treatment is futile, then you have to discontinue the treatment. And even though it is not very clear in Indian law, many experts says there are provisions in Indian Constitution to discontinue the treatment. There are no clear laws about end of life care in such situation. What should be done? Suppose a patient is on ventilator, and um, the treatment is futile, uh, and if there is a relative who also agree with you that okay, this treatment is not needed, we also understand that it is futile, then that patient can be taken out from the ventilator, from the ventilator. But the confusion arises when there is some type of disagreement between the treating team um, uh, and the caregiver, then it is going to be really difficult. But in here, I think you can also continue to inform the police that this is what is being done, and the hospital committee, the committee consisting of expert doctors, have come to a conclusion that this is what we are going to do. That can be informed if you are going to stepping down with treatment. And I think we already told that it is ethically okay to discontinue the treatment when it is futile, when it is inappropriate. The last thing is a problem, and that's why whatever you do, you should document in the case sheet, and the committee should be taking the decision, and that should be informed to the police, so that there would not be much problem in the future. This may not be such an easy thing, but when this occurs, everybody will be confused. What should be done? What would be the after effects, etc. As there are no clear laws regarding this, this is what can be done. And actually, there is another thing in which if the patient is end of life, and if the patient is on
Sorry, sir, you got muted. Sorry.
life sustaining treatment, then the ethical committee can actually can go and file a case in the with the district magistrate, and the district magistrate stating that this patient doesn't need any intervention, these are futile intervention, and then the district magistrate will constitute another committee, expert committee, who will examine the patient and will submit the recommendation to the district magistrate, and they will then that should be followed. But for this, it is very complicated and it will take long time. So we are not sure. So there are some there is no much clarity regarding end of life care situation in India. But as what we can do is constitute a committee consisting of experts and follow the decision and inform the police.
Thank you, sir.
Any other participants have any inputs or queries regarding this?
Yeah, I can see that Dr. Revati Saravanan has can take guidance from the institutional ethical committee. And when there is no improvement, treatment can be discontinued with court order or with some legal help. We do see such destitutes. But when you go to the court, the problem is that we don't know how long it is going to take. It may be months, we don't know, weeks.
Any other
Yeah,
comment?
Sripriya, please unshare the screen. Anybody else has any more comments? Okay, no comments, Sripriya.
Okay, so with your permission, shall we wind up for the day?
Yes.
Thank you, sir. Thank you for joining us. I know that you are on off today, but still you managed to join us for this case presentation. Thank you so much for that on behalf of all the participants. And with that note, before signing off, we have shared the link to do first assignment in the group. Kindly complete that within the deadline. And all the learning materials of all the sessions have been updated in the IECO platform as well. Please do refer those. With that note, this is Sripriya along with Dr. Sunil Kumar signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Bye-bye.